making it out early for coffee and a bite to eat, and a discussion on the impact of science on older Canadians. What we're calling a view from the crystal ball, policies for Canada's aging population. So my name is Bill Dempster with 360 Public Affairs, and it's my privilege to moderate the first panel of the final day at the Canadian Science Policy Conference. It's been an incredible week. I was here yesterday, and the room was absolutely packed. And people are leaning in, learning about where science meets policy, and I think that that's what we're going to continue to do this morning. We've also heard about political and policy shifts throughout the last couple of days, how science is responding to these major changes to the political landscape, both in Canada and around the world. Yesterday's lunch plenary talked a lot about what's happening in the US and how that's going to affect us. And meanwhile, despite all of that, there's a structural shift happening right around us here in Canada, which is projected to continue for the next couple of decades as our population continues to get older, or probably as I should say, how our older population gets bigger. And we're going to hear a lot more about that from our expert from CanAge this morning. So Canadians are looking to policymakers and science hubs for answers and strategies that can help preserve our social, economic, and healthcare systems that are increasingly stressed. So we're going to focus largely today on how innovations in immunization and vaccines are responding to these demographic realities. And this morning's panel of global experts will discuss where we stand in Canada on the current state of vaccine uptake, communication, and vaccine education, and the potential future for precision immunization. We are going to save some time for some audience and delegate questions, so please get those ready. And to kick off the panel and talk about the state of science in immunizations, we have Dr. Ronald Grossman, Professor of Medicine at the University of Toronto, who is one of the world's foremost experts in respiratory tract infections. And I could go on, but that would take much of the time that we have this morning in terms of all the things that Dr. Grossman has done and is still doing. Ron will be followed by Laura Tamblyn-Watts, CEO of CanAge, Canada's National Seniors Advocacy Organization. Laura is a consummate advocate for seniors' health, rights, and well-being, and she will share a sneak peek of CanAge's report card on how provinces are doing on vaccinating their citizens. In batting cleanup, we have Jennifer Chan, Vice President of Policy. Did somebody just fall? No, we're good. I didn't break anything yet. This might happen a bit later.
Still really Bill.
Jennifer Chan, Vice President of Policy and Government Affairs with Merck Canada. Jennifer has an extensive background in the pharmaceutical sector, ranging from clinical research to regulatory affairs, and for over the last 10 years, actually more than 10 years, as head of policy. Jennifer will anchor her comments on a roundtable that brought together experts on vaccine uptake across the country, which, as you may have guessed, has a lot of room for improvement. And if you didn't guess that before, I think by the end of this panel, you're going to understand where those gaps are. However, we're also going to talk about how to actually address a lot of those issues. And with that, I'm going to turn it over to Ron to kick us off and talk about the state of science for vaccines for older Canadians. Ron, thank you.
Right. Thank you very much. It's a great pleasure to be amongst you this morning. I have, I'm told, 13 minutes to tell you everything that you need to know about vaccines, which of course is impossible. So just by way of background, I helped develop guidelines for the management of patients with pneumonia in Canada and the US and internationally. And I've been doing this for several decades. And one of the things that I learned was that it's a hell of a lot easier to prevent infections than it is to treat it, which is why I've developed a major interest in the vaccine arena, because that's where the future is. And as the technology changes and we develop bigger and better vaccines, the biggest barriers seem to be at the governmental level of getting these vaccines approved and delivered to patients who are really in desperate need of these technologies. And the technology that's being developed is really quite fantastic. So I'm going to talk briefly about the science of adult vaccines, just to point out that over the decades, we've had these vaccines that have allowed many of the more important infections, particularly in infants and children, to basically disappear. Tetanus, pertussis, diphtheria, measles, they've all gone away by these vaccines. So vaccines have been the absolute most important medical invention that we've ever had. They do many, many things. They obviously preserve well-being. They decrease the infectious morbidity and mortality. There's enormous benefits to the healthcare system by these new technologies. So what the new technologies really do, besides prevent disease and allow people to live normal lives, is they actually preserve the medical system. As you know, when we had COVID, our system was clearly strained and more or less virtually collapsed. But if we adopt these technologies and we can reduce the infections, the interactions between patients and the healthcare system, it allows the healthcare system to function. So as the population increases and as you'll hear ages, the problem is that we're not spending more and more money to account for this. The adoption of these new technologies allow the system to function. And if we don't adopt these new technologies, I think we'll be once again in the circumstance that we saw with COVID. Vaccination rates for adults in Canada for some entities are quite high, but others are quite low. And the one we're going to be focusing on today is pneumococcal vaccination. The adult vaccination rate for this very important pathogen, this is actually the most important bacterial pathogen causing pneumonia in Canada, is only about 30%. And even in older adults where the vaccines are really strongly recommended, slightly more than 50% of the population have been vaccinated against this very important pathogen. And even the 55% who got a vaccine got one of the older vaccines whose efficacy has always been in some debate. So we have many technologies for vaccines. I'm going to be focusing on the third one, the subunit vaccine. So what happens here is a portion of the bacteria or virus, whatever we're looking at, is isolated, grown in petri dishes, if you will, and then often an adjuvant or some other protein is attached to that subunit of a virus or a bacteria, is then injected into a human being. That subunit gets processed and then presented on the surface of a cell, and then your immune system is turned on, you start making neutralizing antibodies against this. So the technology for pneumococcal vaccine is exactly that. The pneumococcus has a surface made up of sugars, they're called polysaccharides. And the interesting thing about the pneumococcus is everyone thinks it's one bacteria, but it is not. There's 100 different organisms, different serotypes. And these serotypes, these 100 serotypes, behave differently, they even look differently from each other. So the notion that you can prevent pneumococcal disease with a single shot against a single variant of this organism is flawed. So the problem is that we need to identify the serotypes that cause the most common disease and develop vaccines against those serotypes. That's where the technology is quickly evolving. First, understanding the epidemiology of the disease, which serotypes are really important. Then secondly, to develop vaccines to prevent those serotypes that cause the most disease. One of the major problems is nature abhors a vacuum. If you prevent some of these organisms that cause disease over a period of time, other serotypes will replace those serotypes. That's called replacement disease. So you're always chasing your tail here. You always have to give more and better just to keep up with the way nature changes. So pneumococcal vaccines have been demonstrated to really decrease invasive pneumococcal disease in infants, which is shown on the left part of this slide. So infants get meningitis, so there's a dramatic decrease in infantile meningitis because of pneumococcal vaccines. But if you look at the far right of the slide, which are the older individuals, this is stratified by age, you can see over a period of time, not much has happened. So the vaccines were really introduced to prevent pneumococcal disease in kids, and then only later did we realize that pneumococcal disease in adults is really important. But so far, we've not had a major impact on invasive pneumococcal disease in adults. And that's a problem because adults experience a large burden of disease of pneumonia and invasive pneumococcal disease. And in adults, it's bacteremia, sepsis. They don't get meningitis very often. And there are thousands of these cases every year. Individuals are hospitalized, and you can see it's age dependent. Unfortunately, as soon as you hit the age of 50, it's a slippery slope downhill. And by that I mean you develop something called immune senescence. As you hit the age of 50, progressively over the next few decades, your immune system progressively gets weaker and weaker and weaker. That's inevitable, it's inexorable, and we have no interventions that will alter that phenomenon. So the reason older adults are at risk for this disease is because their immune system has been weakened. And when you get hospitalized with community-acquired pneumonia in Canada, bad things can happen. So individuals can end up in intensive care units, they end up on mechanical ventilators, many of them get complications, and the death rate in Canada for pneumonia, if you're over the age of 65 and you get hospitalized with pneumonia, you got about a 1 in 10 chance of dying of that disease. The complication rates in younger individuals are actually even higher than in the older ones, but the mortality tends to occur in the older individuals. So we know that the aged individuals clearly are at risk. Who else is at risk? Well, anybody who's immunocompromised. These are data, again, from Canada, showing that if you're immunocompromised, the likelihood of having invasive pneumococcal disease, that is bacteremia with sepsis and shock, is much, much higher than individuals who are not immunocompromised. And case fatality rates are much higher in individuals with immune compromise compared to individuals whose immune system is normalized. But there are many other conditions that affect the likelihood of having pneumococcal infection. On the far left of this slide, you can see the impact of age. The red columns represent people over the age of 65. The magenta column represents individuals between 50 and 64. And you can see the older individuals are more likely to get pneumococcal disease. But look what happens when you have other illnesses. The worst of the worst there is chronic obstructive lung disease. I'm a respirologist. Those are my patients, people with COPD. But asthmatics, alcoholics, chronic renal disease, chronic liver disease, chronic anything, diabetes, dramatically increases your risk of pneumococcal pneumonia. And on top of that, the risks are additive. So if you're over age 65 and you're diabetic and you have COPD, your risk gets progressively higher and higher and higher. So why do we need new pneumococcal vaccines for adults? Why do we need new technology? And the answer is the disease in adults is not the same as the disease in kids. Pneumococcal vaccines were introduced to children to prevent childhood meningitis. And so the first vaccine, conjugate vaccine that worked really well was called Prevnar 7. It was introduced in the United States in the year 2000. But remember what I talked about before, replacement disease, nature abhors a vacuum. Other serotypes of those 100 showed up. So Prevnar 7 graduated to Prevnar 13. And then because more organisms showed up, 13 graduated to 20. But this is a pediatric vaccine that you keep adding serotype coverage because the old vaccines are not adequate. But what's being shown here is the disease in adults is not the same as the disease in kids. So the yellow circles represent serotypes that are common in children on the left and adults on the right. The blue circles represent serotypes unique to children. And the green serotypes indicate serotypes that are unique to adults. The size of the circle represents the prevalence of that particular serotype. The bigger the circle, more likely that serotype. So the notion that you can give a pediatric vaccine and just keep adding things over time doesn't make a lot of sense when the disease in adults appears to be different than the disease in children. To that end, new vaccines are being introduced. So Prevnar 20 is the vaccine that most of you are familiar with now, that is being covered by the province of Ontario for anybody over the age of 65. But this new vaccine called V116, which Merck has introduced, is a completely different vaccine, which was developed to deal with infections seen in adults. So what this vaccine offers is 8 additional serotypes in adults that Prevnar 20 would not cover. It turns out that based on the most recent data, that this new vaccine will cover close to 80% of the strains that cause invasive pneumococcal disease in adults over the age of 65, whereas Prevnar 20 will cover close to 2/3. So there is a significant difference in favor of this newer vaccine covering those strains which we know cause disease in adults in Canada. What's the future going to look like? Well, we can keep adding in additional strains, and 20 can come 24 or 30, whatever it is. The problem is, as you add in these serotypes, there is an impact on the overall efficacy of the vaccine. The greater the number of serotypes, there is some decreased immune response to these vaccines. Another approach would be what V116 does, which is select different serotypes based on the epidemiology of disease. That's a strategy I think that would work well. We would love to have a vaccine against all 100 serotypes, but we don't. There's been a tremendous amount of research, but it's not happening. There is newer technology that's quite interesting, where you have a scaffold, and then you start sticking antigens on top of the scaffold. The one that's closest to development is called the Multiple Antigen Processing Platform, called the MAP platform. That's on their way. And then maybe nano particles may be coming as well. These are some of the newer adult vaccines in advanced stage of development. So PCV21 is now out. The new MAP platform vaccine is probably another year or two away. Then there's some additional vaccines being developed by a small company in California, which covers even more serotypes. So if I can conclude, the burden of bacterial and viral disease is ever increasing for sure. The older adults are clearly the at-risk population, but anybody who's immunocompromised and has these chronic diseases, things get worse. The vaccine technology is clearly exploding. The vaccine technology and the benefits of vaccination have been very clearly demonstrated over the decades. They are the best invention we've probably ever had in medicine. And we need to be adopting these new technologies in order to keep the medical system operational. So the question at the end is, why isn't everyone at risk vaccinated? So thank you very much, and I'll turn it back to you. Done.
Laura, over to you to explain why isn't everyone at risk vaccinated? It's pretty simple, right?
This is when the doctor and the lawyer get together. This is what happens. Here's the science. Why aren't we doing it, right? It's an excellent question. Show of hands. Who here's actually known someone who's had pneumonia? Raise your hand. Yeah. Who here has had pneumonia? Raise your hand. Who here got it again afterwards? Yeah. I won't ask you who lost someone from pneumonia because it's really early in the morning, and frankly, it's a depressing thing to talk about. I run Canada's National Seniors Advocacy Organization. So we're the people who are trying to say, like, okay, guys, we got the stuff. Thank you. Appreciate it. Researchers, thank you. It doesn't help anyone if it's on the shelf. Or even worse, it doesn't help anyone unless we can actually get it into our system, right? Not just our system, our body system, but our governmental system, our healthcare system. Doesn't help unless we have it. Canada's National Seniors Advocacy Organization, we don't sell anything. We're not here for any other reason. We just want to get the right information to the right people at the right time. And here's the other thing. Anyone here teach also? Yeah, students, people, yeah, okay. So I have a thing with my students, and I say, if you tell me that the population is rapidly aging, and there's not like a Higgs boson thing or a Star Trek analogy somewhere, I'm locking you down a grade. We are not rapidly. It's not like Raiders of the Lost Ark where they open the Ark and then all of a sudden like you die very quickly, right? We knew exactly what was going to happen. It was very, very, very clear. And Silver Tsunami, you know that one? Okay, I'm from Vancouver. We know about tsunamis, and that's not what a tsunami is. A tsunami is an unexpected wave that smashes and then goes away. The millennials are a bigger demographic group than the boomers. Though the Gen Xers were kind of in the screw in the middle, right? But the millennials are bigger in the middle. But you don't hear too many people complaining about how millennials are going to break the system. We complain about why are they having so much avocado toast, right? When we're thinking about things, we have to remember that there's a narrative behind those things. And the narrative is mostly that we don't like old people. We have cuter words for it. We say things like that. But mostly, in the end, it's kind of like that. COVID. We had the worst outcome for older adults in the G20, one of the worst in the world. There was no reason for it. It's just, I need you to cast your mind back. It's March. It's 2020. Close your eyes. Where were you? I got a call from a woman running a long-term care home on March the 14th. Okay. She's crying. Not too far from here, south of Ottawa. She said, I have 87 residents, all very, very high and complex needs. I mean, you know what I'm talking about, right? We built our long-term care system for far less complexity and far less frailty than we have now. And she said, there's me and my administrative assistant. There's nobody else. I can't get anyone to come in, and I have no PPE. I don't even have, like, paper towels. There's no one to cook the food. There's no one to change anyone. We're one of the richest countries in the world. You know who helped? The manicurists. God bless the manicurists. We actually put a call out because all of the PPE was being taken and put in lockers in hospitals. And we said, yeah, that's important, but it's going to be terrible in long-term care. We gotta get gloves, like just gloves, right? We've gotta get gloves. We didn't have vaccines for COVID, but the other thing we said was, prevention is the key here. We need the PPE. The manicurists gave us all of their masks and gloves. I'm not kidding. That is actually who saved the day in Ontario long-term care homes through a WhatsApp group. We're a G8 country. So when I think about our uncharted territory of older people in this country, it looks like this, right? It's not rapid. It's not a tsunami. It's a predicted aging. And it's fine. It's okay. We're not going to break our system as long as we do a few things and not rely on people to give up their French manicures and keep older people in long-term care homes. That's ludicrous. One of the most important things we did during COVID-19 for our older adult population, particularly in long-term care, because we had people in one spot, was we tried to get the vaccination rates up as fast as possible. We tried to get the high-dose flu in specific. We tried to get pneumonia vaccines. We were successful for the high-dose flu. And people said, there's a pneumonia vaccine? Seriously, that's where we were. People knew about flu. In fact, about 1/4 of Canadian seniors have never heard of a pneumonia vaccine, never heard of it. Not only don't have it, never heard of it. And a report that I'm giving you the data from today, I will look at my notes briefly because I have my stats that are dropped this morning. A brand new report says 1/4 of Canadian physicians have never, ever offered it to their patients. Yeah, we know where we're getting older longer, but we have a narrative in our country that we're also aging more healthily, and that's kind of true until it's not. That's actually a lot of I shouldn't say it's nonsense. In fact, Canada has one of the worst frailty health gaps in the G20. We have 8 years of ill health, right? And so, yes, okay, these are the stats. You've seen them. You know that we're doubling. We know that we're doing that. The other piece, of course, is people say, well, why don't we have vaccines in our Canada Health Act, right? Why didn't we put that there? They also say, why didn't we put long-term care in the Canada Health Act? That's a different panel. We'll be talking about that later. When we did the Canada Health Act, the top 10 reasons for death are all now chronic illnesses. Let that sink in. The top 10 reasons for death when we passed the Canada Health Act are all now chronic illnesses. So we weren't actually covering the right things. It's okay, stuff grows. We got, we did better, but it means that our systems didn't change as well. We do advocacy on this issue. You can't say I told you so before, like after the pandemic, but before the pandemic, we were banging around the world. And in fact, the organization that is the umbrella organization globally, the International Federation on Aging, the new Secretary General is here, Gregor Sneddon, give a wave here. There you go, got up early in the morning, yay. The IFA has been banging on about this as well, collectively saying the single most important thing that we can do for an aging population is get vaccines. That's it, like just start there. Eat right and exercise, that's important, but mostly it was important before. As you are aging, the single most important thing you can do is get vaccinated. I talk about why don't we have it, right? We talk about what is policy and what is advocacy. We talk about, well, the policy, which we've talked here, we're identifying the problem. The problem is pretty clear in this, right? We don't have good systems for tendering. We ask public health units at these teeny little budgets to try to figure out what they can afford almost on the back of an envelope. And then that gets rolled up and then everyone else go through your budgeting costings, right? Then that gets rolled up, then that gets cut. Then the number goes to the province. They're like, that's kind of expensive. Do we really need that? I don't know, right? And then at some point, probably there's a purchase for appropriation as opposed to actually doing what we say. In 2019, we said to the federal government, why don't, I have an idea, you take the NACI recommendations, 80% coverage, 90% for other vulnerable groups, and then buy that, and then give it to the provinces, because it would be less than 1% of your public health budget federally if you bought every single vaccine that was necessary. How about we do that? Oh, can't do that. Yes, we can. We did it. It was called COVID. We absolutely did it. It was fine. So we're involved in the advocacy, this persuasion, right? We do have to take kind of that two-lever approach to persuasion. We got to get people to pull the lever, not just the eat right and exercise lever, but to get the vaccines into their body. But that mostly doesn't help, and we have all the evidence that you need, unless it's publicly funded. That other lever, that one that we have to get the government or our public systems to do it and buy it and prioritize it, most people can't or won't get it themselves. We know that. That is the number one issue. So we're trying to do this thing that's in between it by telling people about it, but not isolating them, by making sure that we're persuading. And this is kind of a lot of what we end up doing advocacy between the two. And part of what we do is by laying out these key issues. And we have it in a roadmap, and it looks like this, and we have pretty things, and we are just about to release our next report card. And we're releasing a couple reports, and I'm going to give you, only you know this, like as of this day, yes, only you know this. So we're dropping 2 reports. But here is the pneumonia stuff. This is from last year. I just want to show it to you. This is what we look like in Canada. And we compare it against how NACI actually makes its recommendations and what the funding as well as what the access, and we talk about specific communities, and this was last year's report. We compare them because mostly when you're doing advocacy, the most important thing people want to know is, what is the other jurisdiction doing, right? What is the other jurisdiction doing? But you also need to be able to figure out how it relates to other issues. So when we're talking about vaccination, I'm also talking about dementia. When I'm talking about vaccination, I'm also talking about heart health. When I'm talking about vaccination, we're also talking about lung disease. I want to give you my fresh off, they're actually just almost like wet on the proverbial page. Here's what we know. Every hour, Canadian hospitals spend $145,000 in treating preventative pneumonia cases. Every hour is $145,000 treating preventative pneumonia. That is enough to fund community health centers for a week. Every hour is a week of a community health center. By the time we finish talking today, we will spend enough treating preventative pneumonia in this country to operate a health center for a month. 71 hospital beds are filled daily with preventative pneumonia cases. And at the most generous notion, about half of seniors have some type of pneumonia protection. And I say some type because we were talking to it. We have an annual cost of preventable pneumonia of $1.27 billion in this country. The cost gap is profound. So when I'm doing my policy and advocacy, you gotta persuade. It's the act of persuasion. Why should I fund your thing and not a military aircraft? Why should I fund your thing and not clean water in Indigenous communities? Why should I fund your thing and not a recreation center? These are important things. Because just saying it's good and just saying it's important is not saying it is the most important and the most effective and will help the most people. We saw the most people, we're seniors, and we're going to be even more of the most people. But this is pretty persuasive. Each complex case of pneumonia in this country, as of right now, costs about $21,000. But if they go into the ICU, the average is about $42,000 a case. That is an annual cost of preventing pneumonia, which, by the way, get the vaccine, the 116 in your arm. We're talking about a savings here. It's an annual cost which could actually 100% cover 12,700 nursing positions in this country. Just if we gave them the new pneumonia vaccine. 12,700 nursing positions would be fully funded. But the care gap is real. So what happens after? If you get preventative pneumonia as an older person in this country, it's bad. It's really bad. 23.67% of them will need home care after discharge. Anyone here try to get home care for somebody? How's that? Yeah, that go really well? Do you know, actually, if you're looking for 24/7 home care in this country, just some kind of like healthcare aid or PSW, I'm not talking an RN, it's an average of $300,000 of private pay. If you need about 4 hours a day, every day, 365, we're looking at about $100,000. That's unfunded. That's you paying it. By the way, I don't have that much money. I work for a not-for-profit. Okay. Almost 16%, 15.88% will require long-term care just because they got pneumonia, not for any other reason. And then half will face readmission for this year. So it's a dementia problem, it's a lung health problem, it's a persuasion problem, but we have doctors, right? Well, just to kind of give you a sense, no. Did we make more of those? No, we didn't. But where we did make them, we didn't do it to match our population. So you saw that bulge? Not a lot of kids, lots of older people, lots more people getting older. We right now have about 1 pediatrician for every 2,822 children. We have 1 geriatrician for just about every 21,000 seniors. And remember, family docs just said 1 in 4 have never offered a pneumonia vaccine, and 1 in 4 seniors have never heard a pneumonia vaccine. So our new report is coming out, I think it's next week. You'll see all kinds of good stuff. But when I am trying to tell people, why should you care about this? I care about that recreation center. I care about that clean water. I care about making sure our borders are secure. I absolutely do. But what I'm hoping all of you take out of this is implementing something like 116 funds that healthcare center, funds that recreation center, funds those nurses that we don't have, makes room in our system for our system to improve. And so when I say what the tsunami is, it's not the aging population. The tsunami is if we don't actually get serious about the cost and human gap of not getting these vaccines into the arms of people. Thank you.
Thanks, Laura. So how do we do it, Jennifer?
All right.
Yeah, Jennifer, how do we do it?
Laura, you are a hard act to follow. All right. So first and foremost, thank you so much, Dr. Grossman and Laura, for really helping to set the stage so effectively for us this morning. So number one, very clear, we know that vaccines work. And they are the most important tool in public health for preventing infectious diseases in adults and our older Canadians. At Merck, we've invested in Canada and around the world to really develop and deploy new vaccines. And we've been doing this for a long time, many decades. I have many of my colleagues in the room here today. And vaccines are a real core part of what we do at Merck. But clearly, we can't do it without leading clinical experts and civil society leaders. So, in fact, just because we've been developing vaccines for so long, it doesn't mean that we know everything, we've got it all figured out. So clearly, as you've heard from Laura, there are really major gaps in terms of how and why our at-risk populations are not protected. Dr. Grossman presented to us, and Laura as well, the immunization coverage rates across Canada and between different populations varies. And the report card clearly shows that we've got a lot of gaps, and we really need to figure out how to do better for Canadians. So for instance, again, we spoke a lot this morning about pneumococcal vaccination. And so I think to acknowledge some of the things that are going well. So what we see is pediatric pneumococcal vaccination. It's great. We're seeing vaccine coverage rates in the high 80s. But unfortunately, we're really, really far away from achieving our adult immunization targets. So I think we really, really need to prioritize and start looking at a life course approach to immunization and really taking adult vaccines as seriously as we do in terms of prioritization as we do with the children's vaccinations. So with that in mind, we are truly hopeful that at Merck, like these types of conferences, these types of meetings and dialogue will really help identify and socialize and really help to implement some solutions to really try to fill and close that immunization gap for adults and our older Canadians. And so for this reason, we recently worked with health policy strategists at Santis Health to, as Bill mentioned, to convene a roundtable that brought together different perspectives, including federal and provincial officials, particularly from public health agencies, public health organizations, clinicians, and patient leaders, and really to collectively discuss and align on how Canada can increase vaccine coverage rates across the country. And so I wanted to share quickly with you this morning some of the learnings, some of the things that we heard from that roundtable, as well as some of our own experiences. And I'm truly hoping that everyone can leave this session here this morning with maybe one or two concrete ideas of what we need to do in Canada to really boost vaccine uptake. And I think as well, and equally important, what we can all individually do, but also as part of the organizations that we represent. And so, without further ado, I'm briefly going to run through the 8 themes. And I have to do my slide, this one. Okay, very good. Nope, I'm going to go back. There we go, thank you. So basically the 8 themes that we discussed at this roundtable to enhance vaccines uptake, and hopefully this will spark some dialogue in the session to follow. Okay, so first and foremost, first theme is that at the end of the day, what we're seeing is that healthcare is sometimes overly focused on treatment, which is great, but we need more focus on prevention. So I know we say it a lot, but now we can actually measure the impact of prevention. We know that it's a huge boost to the economy, and it helps to free up health resources when we can increase immunization rates. So there was a recent study that was done by a health data firm, IQVIA, that was commissioned by the Adult Vaccine Alliance. And what that study found was that every dollar that's invested in adult vaccines returns more than $3.50 back to benefits to our health system and our economy. The second theme that we discussed was the need to boost access to vaccinations and facilities. And so we know this is a particular issue with specific communities. So for example, for the First Nations on reserve, we know that roughly a third of First Nations do not have full-time access to medical institutions. We also know that for many of the older Canadians, including those in long-term care homes that are under-vaccinated. So really, could the solution here be to ensure that our vaccine programs are adequately funded and that we can enhance the role of primary care providers and expand the role of pharmacists to administer vaccines. Third theme, we need to build trust through better science communication. And this is really what I think the CSPC is all about. Effective communication is really the foundation in building trust and combating misinformation. And so this really means, again, and thank you, Dr. Grossman, really timely updates on scientific findings and really sharing the reasoning so people understand public health recommendations. Looking at tailored communication strategies that really address the diversity of Canada. And again, on our part, as Merck, we've been working very closely with the Dalla School of Public Health, their Center for Vaccine Preventable Diseases, to help drive that public discourse on the benefits of immunization and also including for older Canadians. Fourth theme, Canada lacks centralized data and registries, and even if you look at the provincial level. So again, the lack of centralized efforts to track various types of vaccines leads to inconsistencies in data collection and reporting. And so looking at the possibility to improve provincial registries and thinking about, wow, Blue Sky Dream is a centralized national vaccine registry. I think that would really help us to identify the underserved populations, and so that we can really focus our vaccine education and deployment and distribution efforts there. Fifth, we need to figure out Canada. How do we handle our jurisdictional silos, our FPT responsibilities? We are a wonderful, incredible federation, but we need national frameworks. National framework to ensure accountability and standards for vaccine access and delivery. Provinces and territories, I think Laura had mentioned this earlier in her session, that provinces and territories can also benefit from greater collaboration by working together, but also being supported by the Public Services and Procurement Canada, also known as PSPC. And their mandate really aligns with working with provincial healthcare systems to really streamline and expedite the vaccine procurement and delivery process to get these new technologies to Canadians as soon as possible. Sixth theme, Canada needs clarity on who is responsible ultimately for the funding. So I think if you all recall, and I think we're just coming up on now 2 decades ago, the federal government launched and implemented its first national immunization strategy. At the time, it was ambitious and it was well funded. So thinking about the economic case for a similar funding approach now, and particularly by adopting a life course approach to close that immunization vaccine coverage rate gap between childhood and adult immunization rates. We know that incremental improvements in boosting vaccine coverage rates, it can lead to supersized benefits. And so the Adult Vaccine Alliance and IQVIA study that I had mentioned earlier, they basically looked at this, and their study showed that even a 10% boost in immunization rates would drive more than $700 million back to benefiting the healthcare system and the economy. Seventh theme, we need to support and continue to support research and vaccine development. And this will be nothing new, especially for the folks in this room, scientists and policy experts, but I think it's truly worth repeating. Canada needs to foster a policy environment that encourages innovation through things like grants, incentives, streamlining the regulatory process so that new technologies can get through the approval process quicker, and leveraging opportunities to drive value through competitive tender opportunities, for example, for new technologies and innovations like vaccines, so that we can bring these new technologies forwards in a way that's sustainable for provinces and territories. At the end of the day, I think nonetheless, we have come a long way. So if we look back just 4 years ago, Canada did not have a life sciences strategy that was focused on driving innovation. But now we do have a federal life sciences strategy. And I think as many of you have heard throughout the course of this week, the government has also stood up the Health Emergency Readiness Canada Agency, or HERC. And we do see life sciences strategies that are being implemented in many provinces across the country. So there is hope here. Eighth and finally, we need to really ensure that immunization education is integrated throughout society. So the roundtable that we convened highlighted that trust was a major gap, and that experts recognize that we need to be able to communicate about vaccines differently, speak about them clearly and consistently about both the relative benefits and the risks. And this means, integrating vaccine education into the school curriculums for the children, leveraging social media campaigns, and really importantly, collaborating with community organizations. And I know this goal is not easy, but ultimately we need to be able to tailor the messaging to specific demographics, and especially those demographics where these immunization gaps exist. So at the end of the day, kind of what was our so what takeaway from this roundtable is that we truly, truly, truly believe that it is going to take a literal village to get a better report card for Canada, and that we're going to need to take a multifaceted approach. So we're looking at education, improving access to vaccines, including for adults, and effective communication. So I think with that, I'll stop there, and very much looking forward to the discussion ahead.
Okay, we have a couple of mics, and you might have a lot of questions. Somebody's already, do you want to jump up? No, this is fantastic.
Hi, my name is Marc Nantel from Niagara College. I want to come in a bit hot this early in the morning. My wife's a family physician, so I know of some of the stuff, or at least I know it secondhand, and I'm vaccinated. But I agree with everything, but I think we're fighting folks who use fear as their weapon. I mean, we're going to have to change tactics. It's ridiculous. When I was chair of scientists in school, an advocacy, a STEM organization for kids, we brought in a person to help us figure out how to better fundraise. And we're scientists, we understand data, we change our minds based on data, we use reason. But the lady said, no, you need to use emotions, which was anathema to us. But I think this is what we're facing here. We could show all the graphs we can to people who are afraid, who fell on Wakefield and his autism bullshit. Sorry, too early in the morning. And now for Robert Kennedy Jr. I mean, are you kidding me? Yeah. This is gonna seep here. Yep. So is it time to start using fear? I don't want to, but I want to know how better we can actually get people who even know about vaccine, but choose not to get it.
Yeah. Do you want me to take it? Want to take it? I'll start off. Thank you. Thank you for that. And I mean, I think it's really important because when we're talking about the gap between the stuff that we think we should do and the stuff that we kind of probably are going to do, and then actually trying to get into sort of hearts and minds and dollars and cents, it's a big shift, right? It's that policy, advocacy, and back and forth. So one of the things actually on a very specific level that our organization has been doing is actually we mentor civil society on actually how to do vaccine advocacy, like for real. Like we actually run classes. And this is a thing that's been picked up at the global level because other countries as well, we're not the only people who do that, but are saying like, we care about this, but how do we do it so that we're addressing misinformation? How do we do it to combat the fear? Like, what are the tactics that you can use at the practical and tactical level that can get the right information to the right people at the right time to make that policy change? And then understand that the context is an evolving and changing one, right? We're in a digital world in many places, and the narratives about how people do economic behavioral change is not just around science. Who here has ever heard that you'll probably be better and healthier if you ate right and exercised? Please raise your hand. Please raise your hand. Okay, who ate right and exercised this morning? I did not. Okay, yeah, fine. No one likes you, actually. No, I'm joking. Right? No, I mean, the reality of circumstance is we'd all be a lot better if we ate right and exercised and, slept and whatever. Someone says, oh, you've lost weight. What are you doing? And someone's like, well, I'm eating hard and exercising. You're like, really? Tell me all about that, right? That's not the point. There's a lot of stuff that we probably know. So you're right. We need to make sure that we're understanding what people have as levers. Some of those levers are get vaccines to people. Don't make people go to vaccines, right? Mobile clinics work really well. I swear I wanted to do a campaign during COVID. You went to the Tim Hortons, and you'd get your double, and like someone would jam you with the vaccine. Like that would be the most effective way that we can do vaccine. And voila, tout le monde. Okay.
Can I just say something?
Yep.
I worked for a community health center during COVID, and I'm sorry to tell you that is exactly how we reached Black communities,
No.
was in their churches. Okay? So I hear what you're saying, but for the last 2 days, what I have heard, mission-driven, innovation, we have all the ingredients, just not the cake. Quantum is a black box. You just don't ask too many questions. Robert F. Kennedy Jr. influenced the city and island of Montreal and all of its boroughs to take the fluoride out of their water.
Yeah.
Okay? So I think I'm a huge supporter. I just joined you, CanAge.
Thanks.
How do we stop standing in our ivory tower?
Yeah.
And how do we reach the people that we need to reach at their level? And it sucks because their level is all feely and like, I'm a doctor on Facebook. I never got a PhD, but I know what I'm talking about because on Facebook. So how?
Yeah.
I get what you're saying, but how do we get there?
Yeah. Thank you.
Yeah, no, that's
Rod-
an existential question. You're quite right.
Ron, I want to give you a chance to jump in.
So you're asking, the previous questioner was asking about raising the notion of fear. So I do a lot of education to practicing physicians. I give lots and lots of talks. And it turns out that the number one reason an individual does not get a vaccine is because their doctor never told them about it. It's not because of the cost, they were just never told. Most patients trust their physician, and if they're advised to do something, generally speaking, they do it. I mean, obviously not routinely, but for the most part, they do it. So when I talk to family physicians, I talk about the consequences of not being vaccinated. So for example, the thing that really kind of wakes primary care physicians up is if you get admitted to hospital with pneumonia, you got about a 1 in 5 chance of having a significant cardiovascular event, mainly a heart attack, but also heart failure. Doctors don't know that. They know about pneumonia, but they don't know about the cardiovascular complications that occur when you get admitted to hospital with one of these serious infections. It doesn't necessarily have to be pneumonia. It could be with RSV, it could be with COVID, it could be with any infectious agent that you get somewhere around 10 to 20% chance of having a heart attack. And the GPs kind of look at me and they go, oh, I didn't know that. It's not something that's routinely known. So when they're informed about some of these very serious consequences of not being vaccinated, they become much more of a champion in promoting vaccination to their patients, and that translates to better uptake. So that's a fear issue in a sense, but it's really knowledge and fear together. It's not just fear, but it's knowledge and fear. And these complications that occur, it could be in anybody. You don't have to have underlying heart disease. It could be anybody walking in the door. 70 years of age, you get pneumonia, you got like a 1 in 5 chance of getting a heart attack. Hello? You don't have to go there. Get vaccinated, you don't go there. So that's part of the process, is to educate the physicians of all of these consequences, and they in turn become champions for vaccination for their patients, and that usually translates to better uptake.
So I think we're running out of time, and Elodie's beside the stage now. Are you advocating a vaccine against misinformation? And is misinformation an infectious disease that actually spreads? Is that what I'm hearing from over here? This is a conversation probably to take throughout the day, but please join me in thanking our panel this morning to kick it off. Have a wonderful day, the last day of the conference at the CSPC. Thank you so much to the organizers.
You're done.